Our next presentation is minilaparotomy, approach to perforated duodenal ulcer. The presenting author is Dr. Tomonori Ohsawa, and the institution is the Department of Digestive Tract and General Surgery, Saitama Medical Center, Saitama Medical School.
Thank you for the opportunity of introduce our study, minilaparotomy approach to perforated duodenal ulcer. I would like to introduce the background and purpose of our study. The technical feasibility of laparoscopic approach to treat perforated duodenal ulcer, called PDU, has been well established. However, laparoscopic procedure for PDU has not been widely performed due to several limitations, such as a longer operation time, a higher cost, and well-trained surgical skills. Purpose: to resolve these disadvantages of laparoscopic surgery, we have attempted to perform minilaparotomy approach, called MA, for PDU based on our favorable results of colon cancer as the alternative method to laparoscopic approach. The aim of this study was to clarify the feasibility, safety, and minimal invasiveness of MA for PDU and compare the results between MA and conventional open surgery. This has shown patients and methods. We investigated 70 patients who were diagnosed as having PDU in our hospital from April 2005 to December 2009. We first analyzed the characteristics of patients who underwent MA successfully compared with the patients in that MA was unsuccessful. The subjects were age, gender, body mass index, ASA physical status classification, the interval from onset to surgery, MPI score, the preoperative intra-abdominal fluid, the actual suctioned fluid volume, and the size of perforation. Next, we evaluated clinical factors and postoperative complications of MA, compared with case-matched 30 patients of PDU who underwent conventional open surgery in our institute before April 2005. The indication of the conservative therapy was chosen when the following conditions were satisfied: the localized peritonitis by the physical examination, steady circulatory dynamics and pulmonary state, less than about 500 milliliter of predicted intra-abdominal fluid volume, and the understanding of conversion to surgery by informed consent. The MA was indicated to the patients with the following conditions: generalized peritonitis, a state of shock with less than about 2,000 milliliter of predicted intra-abdominal fluid volume, and non-shock status, regardless of intra-abdominal fluid volume. For the patients, identified generalized peritonitis with a shock state and more than about 2,000 milliliter of predicted intra-abdominal fluid volume, conventional open laparotomy was performed. As you can see, the figure of actual treatment procedures for perforated duodenal ulcer, there were 70 patients with PDU. Conservative therapy was done for 16 patients when diagnosed as PDU, and 15 patients were improved conservatively. Only one patient received surgical treatment due to the expansion of peritonitis. 43 patients were indicated for MA initially, and 5 patients needed extended the wound. As you can see, the table of patient characteristics. 43 patients were indicated for MA initially. The median age was 53 years. The male and female ratio was 27 to 16. The median body mass index was 90.8. The ASA physical status classification was class 1 in 30 patients, 2 in 9 patients, and 3 in 4 patients. The median MPI score was 12. The median interval from onset to surgery was 9 hours. The median predicted preoperative intra-abdominal fluid was 680 milliliters. The picture shows the surgical scar of MA post-operative 3 months. We defined a MA through an upper midline skin incision with a maximum length of 7 cm. The closure of perforation was almost done by Graham omental patch or simple closure. This slide shows the result of our study. Surgical treatment was performed in 55 patients, 43 patients, 27 males and 16 females were indicated for MA initially. MA was successful in 38 patients, 88.4%, including the converted case from conservative therapy. 5 patients had their wound extended to 10 cm due to the lack of a sufficient surgical field. As you can see the figure, the correlation between preoperative predicted intra-abdominal fluid volume and actual intraoperative suctioned fluid volume in patients received surgical treatment. The preoperative intra-abdominal fluid volume was predicted by the 5-point method reported by Oriuchi. The analysis of correlation was done by Pearson's product moment correlation coefficient. In 43 patients who were attempted to undergo MA, there was significant and positive correlation between the predicted intra-abdominal fluid volume and the intraoperatively suctioned fluid volume. As you can see the table, the comparison of clinical factors between minilaparotomy cases and extended cases. The MPI score was significantly higher in unsuccessful MA cases. Both preoperative and intraoperative fluid were much volume in unsuccessful MA cases. Moreover, the size of perforated site was larger in unsuccessful MA cases. No significance was observed in other factors as indicated. Then we evaluated clinical factors and postoperative complications of MA compared with the 30 patients of PDU who underwent conventional open surgery shown in table. In comparison of leukocyte count and C-reactive protein CRP levels, CRP on POD4 was significantly lower. The number of analgesic use was fewer in MA groups. The first passage of gas and the start day of oral intake were also significantly earlier in MA groups, respectively. The postoperative hospital stay in MA groups was shorter than that in control groups. Postoperative complications in MA groups included intra-abdominal abscess in 2 patients, wound infection in 4, while it in open laparotomy groups included intra-abdominal abscess in 1 patient, pneumonia in 2, and wound infection in 5. There was no postoperative mortality. Conclusion. Our studies suggest that MA for perforated duodenal ulcer could be an acceptable method to perform the surgery safely, resulting in minimal invasiveness for patients as well as laparoscopic surgery. It will be necessary to validate the usefulness of MA for PDU compared with laparoscopic procedure by a randomized trial in the future. Thank you.
I enc-